how many of you are anterior segment or posterior segment people? How many of you use OCT on a regular basis? So what I would recommend is when you see a OCT, just give you some tips that you see 4 things. You see the normal contour. So even if you don't know how to read a OCT, just think of 4 things. What is the normal contour? Is the too dipped, it's thin, or it's elevated is the ERM. Number 2 is what is the vitreometal interface? Can you see a membrane or not? Number 3 is the thickness. You may have a normal edema, you may have a normal contour, but you may have the thickening or a thinning. Number 4 is the IS-OS junction, this which Dr. Jha showed, small one. If that is injured, then you have a damage to the retina. It's not true. So all unexplained visual losses, what we recommend, fields and an OCT to pick up any vision loss. Number 2, you have any patient of cataract and you feel that the cataract is not commensurate with the vision loss, get a OCT done, that is an indication. Number 3, that all of you are doing premium lenses. So the premium lens, whether it's even a toric, get a OCT done before, because you may have some membranes and the patient will not respond. So that one of the unhappy patients after cataract surgery is a patient whose OCT hasn't been done. So, right, so normally you end up doing an OCT after the surgery, get it done before the surgery if you're doing premium or patient expectancy are higher. And especially in diabetics, sometimes you may have a small vacuole or CME which will not picked up clinically, you may have no microaneurysms. So those patients who have suspected macular diabetes, hypertension, who had BRB or CRB, remember that you don't need to go into the layers, just see the thickness, the contour, the interface and the IS-OS junction, you will be fine. So the topic I am speaking is more limited to the retinal surgeon, but it will give you a future where we are going. So 1998, I think the OCT was started. It took about 12 years for them to analyze the vessels of the retina. So basically on the fluorescent angiography, you get a foveal avascular zone. On the OCT, the en-face, you can have an idea. But the retina has the superficial retinal vessel and you have a deep capillary plexus and superficial capillary plexus. So you get the motion artifact. So whatever is moving, you will be able to find out. If it's not moving, you will find it as a blocked artery, right? So will FA be replaced? It is being replaced, but finally will it be, because the leakage is not picked up by the OCT angio. It will not show pooling. So sometimes in a diabetic, you may have no CME, nothing, but we do FA, there is a mild leakage, means the retinopathy has started, but the OCT angio will not show any dye and uveitis, will not show any changes thereafter. So the dye-based angiography is low resolution and the OCT takes less time, the less flash, and can be done multiple. Repeatability, non-invasive, that is where the OCTA is scoring higher. So if I have to show that normally we have 3 layers. So there is the superficial, deep and the intermediate, but majority of them of the OCT angio just show the superficial and the deep layers. So what we have learned from OCTA is that each layer infarct can cause some other problem. So if you have an artery, you have arterial occlusion, venous, but if there is a capillary occlusion, superficial nerve fiber will be a soft exudate. So you can have PAN, you can have, so there are 3-4 terminologies come for infarct of each layer. So you see a whitish patch and the OCT angio will tell you which layer it's getting affected. I'll show you the details. So basically the superficial capillary plexus and the deep capillary plexus, which has an intermediate capillary plexus. So different OCTs show a different flow sign. So this is the superficial and the deep vascular plexus. If I were to do an OCT angio on different machines, there's a different segmentation, different, the resolution is different. So you will see a different pattern on each, but it shows up the foveal avascular zone. This is the chorea capillaries. You can go to the level of the chorial capillaries. So there are various machines which use different sources of software, with some are HD, one are swept source, and the resolution is different, and they are increasing the resolution. The only issue is that all our OCTs, I have superficial ones. Only the swept source can go deep, or you have an EDI where you press and you segment each layer separately. So as I mentioned, different segmentation layers and different scans. So any stationary object will not be seen. It is just that the motion artifacts which you see, the movement you see. So these are the various machines and how you can see the various layers of the, so the superficial, deep, and the choriocapillaries. So does it have a role over what is missed in a OCT, which you need a OCT angioform? Basically, choroidal neovascular membrane. So we are taught that a choroidal neovascular membrane leaks, and when it leaks, it causes edema. You treat. So if I have a choroidal neovascular membrane which is not leaking, so do I need to treat? Yes, if there's metamorphopsia, but if there's a subretinal membrane which is not leaking, which is not causing metamorphopsia, you may not treat. That is a doubtful indication. But yes, if you have metamorphopsia, some CNVMs don't leak, like the myopic. So you may have no fluid, just the distortion. Difficult to differentiate in a PED with CSR. So as I mentioned, in a CNVM when going from dry to wet, and does the presence of a CNVM on OCTA help me retreat? No, it's a controversy. If it's dry, you may not treat. It's not going to disappear. This is a very good indication. We had to do a ICG to pick up a CNVM in a patient with CSR. In uveitis, sometimes you have a CNVM in a serpiginous light where you miss out and think it's just a recurrence of the edema. Diabetic retinopathy, we all are worried because of the angiography. The angiography gives us a better clue. But yes, this is picking up the NVDs, NVs, and the macular ischemia. So it's non-invasive, repetitive. You can't do a FA repeatedly, but it is helping us. In BRVO, it is giving us a sense of the ischemia. But if you go to the BRVO and CRVO study, it said so many disc diameters of ischemia. Since the OCT only gives us the posterior pole, 12 by 12, we do not see the peripheral ischemia, which is only visible on a fluorescent angiography. Now in the MACTEL, Dr. Jha showed the atrophy, telangiectasia, which you want to pick up a CNVM. So here is a type 1 CNVM, which is visible. You can see the net form, which comes in the. So basically, you're looking for a CNVM. This is type 2 CNVM, which looks different. You can compare with the FA, and this is the polyps, which can come up. You see the polyps on this. So basically, OCT angio is basically for the CNVMs, not for anything else in the retina. So what is the disadvantage? There's no leakage, no pooling. But sometimes if there's no pooling, you can pick up the CNVM. Sometimes the early and the late leakage blurs the CNVM on angiography. So you need to have a OCT angio when in doubt. So suspicious CNVM complicating CSR helps you pick up. So here you can see but the only problem is that the machine segmentation is the problem. See, when you're doing a normal OCT, you have a straight line. But when there's an elevation, the machine itself does not segment this layer. It will just take a line here. So you have to manually then reset. So it can't be done by a technician. OCT has to be done by you because you will have to create this layer. The segmentation is going to be poor. Sometimes a simple NV looks like a CNVM because the retina is elevated. So as I mentioned that I have seen a CNVM, but there's no fluid. There's no metamorphopsia. Doesn't mean that every CNVM has to be treated, because if it's not leaking and it's dry, you may just wait. Injection is not to make the CNVM disappear, it's just to keep the retina dry. So what happens in a diabetic? You see the elevation coming up. So between an IRMA, which is a ischemic, but is it a new vessel on leakage? The elevation in the vessel over the retina will tell you a new vessel is being formed. So on trial basis, they have made huge machines which can tap the whole retina end to end for a angiography for trials. It's not commercially available, but they're even doing just a OCT of the whole retina in ROP screening, but they can see the vessels coming up. So tomorrow, as it becomes reproducible, you will have OCTs which can map the whole posterior pole up to the ora. But they are too bulky research tools. So you're going to have them picking up the NVs and the NVDs, which you may not want to do an angiography. So here you can see a patient with an NVD, and you can see the elevations of the NVDs coming up. So you have to learn, and it's difficult doing it and interpreting the OCT angio. It's a learning phase. Maybe in the next 2-3 years we have. Here the NV is there. You can see the NV. So what people are now using is trying to map the posterior pole for diabetic retinopathies, looking for the ischemia. The micronism will not look. They look like saccular pouching on this. So can I pick up early diabetic on OCT? You may. But remember, if you are doing fundus photography, I'll advise all of you to buy a fundus camera, whether you're anterior or posterior segment surgeon. They are coming and you do regular photographs on diabetic. If you do a red free, you will pick up the micronism better. So a red-free photograph gives you a huge finding. And if you can buy a contact lens and use on a slit lamp and you can do a wide angle 3 mirror, you will pick up a lot of lesions. So if you want to correlate your OCT, learn to do a 3 mirror or a wide angle mainstay lens so you can see the whole retina. You can see the NV there. So MACTEL, you can see the abnormal vessels, but you don't see the CNVM. In a BR view, I told you, you can see the ischemic areas, how much the ischemia is, and it's easier to explain to the patient. So sometimes, as I mentioned, the segmentation is going to go straight. If there's a bump, you will have an abnormal, so you'll have to reset it here. So this is the normal segmentation. Manually, you have to resegment it to get the right layer on a OCT angio. So what are the disadvantages? One is motion artifact, because it takes time more than an OCT. The movements create some motion artifact. You see these lines, right? So they are the biggest problem in trying to understand a OCT angio. And the tracking, if the patient is moving, the tracking. So the SLO systems track better. They have better penetration through this thing. And if you have a blood, again, you cannot see the CNVM properly. So the limitations I mentioned was that some start with 3x3, some 6x6. Now up to 12 we have the mosaic. So they superimpose 4 or 5 photograph and create a mosaic. So you see it like a fluorescent angiography. So in summary, it is a diagnostic tool still basically for CNVM, but we don't know what is the best answer to treating. So I'll just show you a few cases. This is a CNVM now that you have seen multiple ones. It looks nice, but sometimes you have a very dilemma, is it or is it not a CNVM? Here you can see the lesion, the infiltration, and you may have a RP rip. This is a CNVM without a fluid. So this is called a SHREM, subretinal hyperreflective material. So in a choroiditis on a person, when you see a SHREM, subretinal hyperreflective material, you do a OCT angio or a fluorescent angio to look for CNVM. So SHREM, only 15% will be CNVMs. So myopic, as I mentioned, you may have metamorphopsia, you may not have fluid. So normally a normal OCT will not help you monitor a myopic CNVM. Either you have to do a fluorescent angiography to see where it's there, or a OCTA. A simple OCT sometimes does not help you pick up a CNVM in myopic. So as we mentioned, sometimes you have chronic CSRs where you have PEDs and then you cannot pick up. So the OCT angio will help you pick up the neovascularization. So I'm just showing you a few examples. We've already discussed the fluids. CNVM in fluid, you can see sometimes the resolution of the CNVM also on the OCTA. So basically, as I mentioned, CNVM is the most important parameter, but if you have a good OCT and resolution, you can pick up the fluid. You do not, once you've diagnosed one, follow up, you do not require OCTA. OCTA is only required when you have a doubt of a CNVM to diagnose a one, and that also when there is fluid. Thank you so much.
Thank you, Dr. Amit, for highlighting the features of OCTA. Now I invite Dr.